Good morning, everyone. My name is Sinead Delaney Moretwe, and I'm from Wits University in Johannesburg. And I'm delighted to see you all in the room this early. It's great to have such a packed audience for this session. I am going to start by introducing the session and then hand over to my colleague, Veronica Miller from the Forum, to continue chairing the session. So in this session, what we hope to do is share with you some of the context and deliberations of a meeting that we hosted to really consider opportunities for enhancing pre-exposure prophylaxis. And pre-exposure prophylaxis is an important strategy for HIV prevention. And there are many opportunities emerging with the development of new antiretroviral agents, particularly long-acting agents, that could potentially simplify implementation of PEP programs and potentially improve their coverage and effectiveness. But one of the limitations of designing trials to evaluate new products is actually that there's very little trial data on PEP efficacy, and it's been a challenge over many years to develop those trials for obvious reasons. And what this has meant is that we really don't have an indication on any labels, so any regulatory indications for PEP. And it may be important to have that as we move forward because of the potential to have better program adoption for countries that need regulatory approvals, but also for medical insurance schemes that might only approve if there is an indication. And also, it would help inform then kind of the best implementation practice. So given this context, there was a real opportunity to develop consensus and to consider the role that a comprehensive package of information that might include preclinical data as well as considerations for what we know about pharmacokinetic and pharmacodynamic data, as well as considering a number of trial designs that potentially could be adopted to evaluate the effectiveness of new PEP regimens. So the summit was held in May in Johannesburg in collaboration with Wits RHI, which is my institution, and the Forum for Collaborative Research. And really the focus of the meeting was to develop or consider how best to generate evidence for long-acting antiretroviral-based PEP. And the idea was to consider both what was required for normative guidelines, so for example, considerations for CDC or WHO or other guidelines, but also considerations for what might be required for regulatory approval. And as part of the deliberations, we were product agnostic, so we reviewed a number of agents that might be available in the future, but most of the considerations were product agnostic. And I think one of the important things that we learned through those conversations really is that normative guidelines versus regulatory approval aren't an either-or consideration. They may both be important, may have different emphases, but generally they consider the same evidence, and we really need robust evidence for both of these purposes. So it's not that one might require less evidence than the other. And I think this is really an important outcome of those discussions. The value of having the meeting in Johannesburg is really that it provides an opportunity to highlight the importance of HIV prevention, particularly in the African context. And what it allowed really is voices that might not otherwise be have access to these conversations to be in the room and to be heard. And this is particularly important given the high burden of HIV in Eastern and Southern Africa, but also kind of the recent disruptions to funding, particularly in the African region, and the consequences for HIV prevention programs and the renewed or kind of new emphasis of national programs having to consider what the specific needs of the region, but also their programs might have in terms of prevention. But this wasn't an exclusively African focus, and we included implementation models from Brazil and the US, and you'll hear from some of those colleagues today. And it was really important, I think, to share cross-regional learnings and to develop consensus around a common approach. The meeting focused on several use cases, and given sort of where we were, a lot of consideration was given particularly to adolescent girls and young women, but also sexual assault survivors and men who have sex with men. But, kind of we felt that many of these considerations of use cases might be applied to other use cases, particularly occupational use. And the settings that we considered were really the typical setting where people might access PEP, like sexual assault centers or community-based dispensing or pharmacy-based dispensing. And there was some discussion of PEP in pocket and vending machines, but from a trial perspective, we focused very much on people presenting following a potential exposure and requesting PEP. And the real strength, I think, of this workshop is that it allowed for the contributions of many people and many perspectives. And so in the room we had community representatives and end users. We had regulators, normative organizations like WHO, academics and clinical researchers, biostatisticians who can provide insight into trial design, people involved in program implementation, as well as partners from the pharmaceutical industry. And that made for a very rich discussion, and you will hear some of that reflected in today's conversation. So with that, I'm going to hand over to Veronica.
Thank you, Sinead, for that super introduction. I just wanted to follow up with really thanking this very, I think, impressive group. If you won't have time to read every single name, but first of all, thanking Helen and Ken Mayer for co-leading this project with us. And we don't have the WITS logo on every slide. I'm sorry, that was my fault as I was doing them, but it was such a good collaboration with the WITS RHI that really made this happen. But we had people from academia, we had people from regulatory, especially quite a few, of course EMA and FDA, but quite a few people from the African continent. We had our industry experts, our community experts. We had the Gates Foundation, and we had people from CHAI also participating in our group discussions. We covered ethics. We had multilateral agencies there as well as people from the US CDC. So it was really quite a wide range of stakeholders that we were able to bring together. So the consensus, the very broad consensus was that, as Sinead already outlined, the importance of evidence-based guidelines for normative bodies for new antiretrovirals with potentials for PEP. The importance of considering a regulatory indication for PEP to facilitate implementation, broad access and coverage among those who need PEP, need for a simple pragmatic protocol to generate this evidence to support guidelines and potential regulatory authorities' approval. And we also reached an agreement with the regulators that were there to convene another meeting specifically with EMA, EMA, and SAPRA, the South African agencies, to continue these discussions. This is a group photo taken against one of the beautiful walls at the WITS RHI, and really want to thank all of those who were able to be present. And want to thank the Gates Foundation for funding this project. The HIV Forum also does receive funding from our pharmaceutical partners, ViiV, Merck, and Gilead. The project leadership, again, and working group members, HIV Forum management, Logan Donaldson, who was here, and also I thought I'd put in Christopher Berry, who is our events manager, and the WITS team was absolutely fabulous in supporting us while we were there. So with that, we'll go right into the presentations.
And our first presenter this morning is Andrew Mujigira. Andrew is head of the Infectious Diseases Institute, Kasangati, at Makerere University in Uganda. And he has over 10 years of experience with oral PrEP efficacy trials, demonstration projects, and implementation studies. And he is going to give us a wonderful overview of the key findings from the summit.
Thank you, Sinead. Good morning. These are my disclosures. So as you have heard, the PrEP field exists in a very interesting space where no current PrEP regimen was approved based on any RCT evidence, and yet we need randomized trial evidence to get a label indication. And you have heard about the Johannesburg workshop and how various stakeholders came together to achieve consensus on the path forward. Can we do clinical trials that are ethical, acceptable, inclusive, efficient, and feasible? So we acknowledge that it's going to be really difficult to get RCT evidence for HIV PrEP, but this is a key justification for adopting innovative trial designs to get the evidence that regulators will need. So PrEP is essentially a race against time. As HIV enters the body, it establishes a founder population within 2 hours to 3 days, about 40 to 50 productively infected cells in the genital mucosa. And then it expands locally to the draining lymph nodes through immune activation, recruiting susceptible cells. And this is the window at which PrEP has to be started before HIV disseminates systemically. So early initiation of PrEP keeps the founder population small, and taking PrEP for a sufficient duration of time blocks local expansion. So these are the two biological pillars of PrEP efficacy. Now, there's an interesting question in the field. For 3 decades, we've given PrEP for 28 days, and this is based on animal macaque data and work done in Brazil by Mario Schefter and published in 2004. And yet we know that less than 60% of people complete the full course, but we do not see breakthrough infections. They're very rare. So do we still need 28 days? Modeling studies suggest that if you take 3 drugs within 48 hours, you get up to 90% efficacy. But most people don't really initiate in 24 hours. So they really need to take the full course with the data and the knowledge that we have. So we really need to get PrEP to people as soon as possible, within the first 24 hours. And one of the strategies we can use is vending machines. Our colleagues here in Brazil have a vending machine at the conference, Pavilion 3, which you should check out. And we can also use PrEP in pocket, where you give people a whole 28-day supply at places like sex work venues, or maybe even police stations or clinics where sexual assault survivors go. The workshop evaluated 4 designs that we could use for PrEP: a counterfactual placebo, a pragmatic trial, a preference trial, and a zero-event trial. I'm going to walk you through these 4 designs that we discussed at the workshop. A counterfactual placebo is essentially an active controlled trial comparing a novel, longer-acting PrEP agent against the standard of care, and it uses a counterfactual placebo cohort, not an actual placebo, but a counterfactual one. And we have seen these designs used in the lenacapavir trials, PURPOSE 1 and PURPOSE 2, and those data were accepted by the FDA and other regulators. If you compare the sample size required for a non-inferiority trial versus a counterfactual design, you can see that a non-inferiority trial would be technically infeasible, requiring about 12,500 people to generate about 50 events. But if you use a counterfactual design, you lower that sample size to less than 4,000, and you only require to see about 14 HIV acquisitions. So the counterfactual approach is statistically efficient because it reduces your sample size considerably by about 70% relative to a standard non-inferiority design. Of course, you have to engage with the regulators to accept your epidemiologic assumptions. The limitations of counterfactual design are, again, that finding 4,000 non-PrEP users at risk and following them for 2 years is also challenging because you need to do a large multi-site trial, and there are not many people that can fund that level of effort. Second, PrEP cohorts can be dynamic with people switching to PrEP during the trial, as we saw in the ANRS Prevenir study. Yeah, and if you lose 40% of your cohort, that is significant attrition and loss of statistical power. And then thirdly, you are presenting data which relies on epidemiologic assumptions that are modeled. And so the degree of regulatory acceptance for this kind of design, although we've seen it in PURPOSE 1, it remains in uncharted territory for PEP. So the first design gives us efficiency. It is technically hard to do, and you have regulatory hurdles that may limit how well we can use it in the real world. The second design is a pragmatic trial, where we, as you've heard, we can enroll 3 cohorts of men who have sex with men, female sexual assault survivors, and healthcare workers occupationally exposed, and compare a single dose long-acting agent with standard of care. And the primary endpoint here is simply behavioral. What proportion complete their regimen? We expect completion to be nearly 100% for single dose PEP and about 50 to 65% for standard of care. And we think that that gives us high statistical power. However, a regulator like the FDA is going to want you to show that you can prove biological efficacy. And they need to see PK data showing that the drug upholds viral replication. And simply completing the regimen does not satisfy that requirement. The third design is a preference trial, which combines a randomized trial with an observational cohort. So you get people that are eligible for PEP, and they choose whether they want to be randomized to intervention A or B, or they decline randomization. Those who accept to be randomized are randomized, and those who decline get to choose. Either they take intervention A or B, or no PEP at all. And then you follow them and assess your outcomes. This design is modeled after CoVPN 3006, and it is preferred because it accommodates participant preferences. And this design is best suited for an open label extension once a drug has been proven biologically effective. The challenges with this is that the proportion of participants who are willing to be randomized is unknown. So you may find more people in your observational cohort than in the randomized arms, which inflates the sample size. However, it gives you real-world preference data and treatment effects in the same trial, so you don't have to do a randomized trial and then do a demonstration project to capture feasibility, acceptability, and other preferences. You can do it all in the same study, which is efficient. And it gives your ministries of health and other authorities real-world data alongside trial data. The fourth design is a zero-event trial, which is helpful when you're evaluating a highly effective PrEP products in low-incidence settings, and when you anticipate that there will be very few breakthrough infections. So this is the current consensus design that emerged from the workshop, and it requires us to think a little differently. We are so used to counting breakthrough events, HIV acquisitions, but this design simply accumulates a large volume of prospective exposure data with the goal of establishing a statistically rigorous upper 95 confidence bound on the underlying or the background infection rate. So you build evidence through the absence of HIV acquisition, not the occurrence of HIV acquisition. So that's the difference. You're accumulating data that PrEP is working by preventing infections. So you could do it in one of two ways. Follow a cohort of people who have acute exposures document the time they were exposed, when they started taking PEP, how they took the PEP, and any outcomes. And this gives you per exposure data that you can use to inform your PK modeling. Another pathway is a PEP in pocket cohort, where you enroll people longitudinally and follow them up and document repeated exposure events within the same person over time. And this allows you to estimate person-year incidence rates with high precision. So this summarizes statistical benchmarks that we use. We think enrolling 1,000 to 2,000 people and following them for a year is sufficient to give us an upper bound of 0.3 per 100 person years, which we think is potentially sufficient for regulators. And the table that you see has on the left side the number of exposures required, and on the right side, the upper 95% limit. And you can see that as you double the number of exposures, you have the upper 95 confidence limit. We think the sweet spot is about 2,000 exposures if we enrolled about 1,000 individuals. And we think the equivalent incidence would be about 1.8 by 100 person years, and an upper bound of 0.3 per 100 person years. So we think that this is the sweet spot or the target sample size for a zero event trial for PEP. The advantages of design are many. It is feasible to do when evaluating highly effective, probably single dose PEP candidates. You don't need to see any HIV acquisitions. You can provide regulators with statistical upper bound that is standardized and quantifiable. You can measure per exposure efficacy, which is important. You don't need to enroll a large sample size for non-inferiority, and you can sequentially accumulate evidence of effectiveness. And this is really optimized for low incidence settings. We have over 90% virus suppression in many countries now, and this is where we expect very few breakthrough events. So we need this kind of novel design. So tying it all together, we compare all the four designs. The counterfactual placebo, all four designs are ethically high, but the counterfactual placebo is really hard to do. But when you look at the bottom line, the zero event trial, it's ethical, it's feasible, you can give you regulatory certainty with the evidence you generate, it's statistically efficient, and you can get the biological evidence you need. So relative to the other three, we think this one hits a sweet spot in all five areas that we need. And so the design one is viable as a regulatory precedent for models placebo arms, as we have seen in Purpose 1. Design 2 works best as an open label extension. Design 3 can give you supplementary evidence for label claims if you want to understand preferences for adherence and access. So the key takeaways from this talk is that we should tailor the evidentiary bar to the standard of care. We shouldn't require long-acting PrEP candidates to meet standards that were not met for the currently used oral regimens. And so we are innovating in trial design not as a shortcut, but out of scientific necessity, given the challenges of doing the standard non-inferiority PrEP trial. Second, that really for now we need to take all 28 days because most people don't initiate within 24 hours, but we should increase access to PEP in pocket and vending machines, and these are things that we should build into our trials. Thirdly, that the zero event trial redefines what we understand by evidence in near zero incidence settings. So through accumulating thousands of observations, we can get a credible proof of biological protection for regulators. And so we treat the upper 95 confidence bound as a primary efficacy metric instead of relying on breakthrough events. And then fourth, we are continuing to engage with regulators to see how we can pre-specify the evidence that they need to see for such a trial. With that, I would like to thank you for your attention. I would like to thank the forum, the leadership of the forum, and the statisticians who helped put this talk together. Thank you very much for your time.
Good. Thank you so much, Andrew, for that very concise and so well explained summary. It's my pleasure now to introduce Max Latiad, who is the head of the HIV drug development at the Gates Foundation. And he comes to this topic with both various perspectives from the Gates Foundation, but also his previous experience in industry. So we really look forward to your comments.
Thank you very much. It's a pleasure, really, to see the sort of thinking we've been doing, and now it's starting to shift into a potential phase 3. I want to talk to you a little bit about a Gates Foundation perspective, really about how we think about what the future looks like from an HIV perspective, and how we have evolved our target product profiles to be more in line with how the field is moving forward. So when I first joined the foundation, one of the things we worked on was target product profiles. So what do we want our products to look like as we move in the future? And what sort of programs or products are we going to be funding in terms of ideas? So we looked at long-acting oral agents that can be used for treatment, PrEP, and PEP, long-acting injectables that could be used for treatment and PrEP, and potentially an implant that could be used every 4 years. So we decided to focus on those 3 target product profiles moving forward. Next, we also look at target medicine profile. And for those of you that are not really in industry, target medicine profiles are the profiles of the medicine that are going to go into the patients. And here, again, sticking with our 3 target product profiles, our target medicine profiles range from once a month oral, once a week oral, to twice a year injectable. Again, for PEP, you can see that we took a look at once a week oral or once a month oral, thinking about what will be available soon and potentially what can be available in the future. So when we think about our strategy, we felt that a strategy that could be successful is one that can succeed without the state of the infrastructure of the country where this drug is going to be introduced. So we like the idea of our core strategy to be centered around a long-acting oral agent that can be used either for treatment or PrEP or PEP. But in addition to that, what we call a core strategy plus is one where we feel if we engage with pharma companies early enough, we could have a long-acting every 6-month strategy that is implementable in lower and middle income countries as well, which is why you see that we are monitoring the progress of the 6-month injectables from Gilead, from Merck, and also from ViiV. So if you think about what the future looks like from our perspective, we would like to see treatment move from 365 days a year to just about 1 pill per month or 2 injections a year. PrEP, similarly, we feel could be 1 pill per month in the future or 1 injection yearly. I think the bi-yearly LEN injection now is progressing to potentially yearly. And then PEP, if you think about what we are doing here, is potentially moving from 28 days to maybe 4 pills, if you think about a weekly agent being used for PEP, to potentially 1 pill for 1 exposure. So many times in my career in pharma, I've been part of what's called the innovation, right? So putting out their innovative product. And a few times I felt that the innovation that's being produced is actually being implemented in silos. So PrEP here or PEP there and treatment there. And so we feel that a properly implemented strategy is one that is integrated, right? And so if you had a patient walk into a clinic and the patient was diagnosed with HIV, you would treat that patient so that they're undetectable and cannot transmit the disease. But at the same time, if they were HIV negative, and within the window of PEP, you would give them PEP But before they walk out of the clinic, talk to them about PrEP as well. So I think that integrated strategy, that's the one that's the winning strategy moving forward. So what we do usually at the Gates Foundation yearly is a meeting where we talk about the strategy for drugs, the strategy for vaccines, the strategy for TB, drugs and TB vaccines as well. And so at that meeting, it's really about putting your whole year on one or two slides when we present to the Gates senior leadership team. So last year, we kind of explained what we did for the year. We said, hey, we created target product profiles. We have agents that we are following. In the middle, this is where we present our new strategy of 1 pill once a month across indication. And we felt that it was simple enough, and we had the potential assets to create a strategy where this could be introduced in LMICs regardless of the state of the infrastructure. All the way on the right, it has to be cost effective, and not surprisingly, compared to the injectable, the long-acting oral agents were felt to be quite cost effective. If you think about the agents we are following, in the future, given the lack of funding that is happening now from the US government, we feel that industry partners are going to be the key partners for us to work with to bring this innovation to LMICs. In the middle, and I'm going to make it bigger for you, we took a look at the impact of PrEP, PEP, and treatment in 5 of our priority countries. When you look at the top part, you can see that the majority of the lifting is being done by PrEP. But when you take a look at the bottom part in terms of preventing deaths, the treatment is doing a lot of the work because you're preventing people from getting to AIDS and preventing people from dying. All in all, when you use the treatment PEP and PrEP together, you have just about a 3-fold impact compared to using them separately. So together over a 20-year period, if you use all 3 together, you're looking at avoiding 15 to 20 million infections in 55 LMICs. Last but not least, I want to share with you what our vision looks like on one slide, and it's really focused on the number 1. And it's about 1 pill, 1 time for PEP, 1 pill monthly for PrEP, 1 pill monthly for treatment, and potentially 1 injection a year for PrEP, and 1+1. I'm cheating here because those are 2 injections bi-yearly, and then 1 implant every 4 years. That is where our ambitions are in terms of where we want to be 5-10 years from now, so that we can have impact for another 10 to 15. Lastly, this is showing you where we are investing, sticking with our strategy, and whenever we are funding something, that it has to be on strategy. So I'll leave you with this graph, and internally, we've been thinking about if we properly implement the long-acting agents, whether it's long-acting oral or injectable, with prevention alone, we can decrease the HIV epidemic over a 20-year period by a full log. That's 76% decrease. If you think of where we were in 2004, we were at 2.65, 2.7 million infections a year. In 2024, 20 years later, we decreased it to about 1.3. We think that in a 20-year period, we could seriously decrease the HIV epidemic with long-acting PrEP. But when you use PrEP, PEP, and PEP together, you can see that we are almost approaching the HIV elimination strategy, which is ending the HIV epidemic by ending HIV transmission. I think if we do that, then we leave the world in a better place for a vaccine or a potential cure. This is the team that's working on the HIV drugs program at the Gates Foundation. And thank you very much for your attention.
It gives me great pleasure now to introduce our next speaker, Adobe Olesa, who is from Nigeria and the project lead at Root to Rise, a global health nonprofit organization working to ensure life-saving health innovations reach the communities that need them most. And she's going to share with us the community perspective that was integral to the workshop in Johannesburg.
Hi. It's an honor to be here today representing the community representing Root to Rise and sharing some perspectives from the community voices. So over the next few minutes, we're going to be discussing the PEP paradox. We'll highlight current gaps in PEP uptake and how it's linked to community engagement. We'll hear some insights from community voices. We will also discuss country-level considerations and end with next steps. But I would like to start with a disclaimer. The community perspectives and survey responses I'll be sharing in this presentation are not scientific research. They come from a short informal survey that was shared through community WhatsApp groups and networks ahead of this presentation today. The sample size is small and is self-selected, so the findings are not statistically representative or generalizable. In summary, this is not scientific research. What it is real, unfiltered community voices that was shared willingly to help ensure that lived experiences and community preferences are elevated as we discuss the future of PEP. So let's start from the basics. Post-exposure prophylaxis PEP is a 28-day course of HIV medicines that is taken after a possible exposure to stop HIV from taking hold. Thanks to Dr. Andrew for the scientific explanation he gave about how PEP works. And in his presentation, we saw why the key to PEP effectiveness is speed. There's a timeline. It has to be started within 72 hours, ideally within 24 hours. And it is also for anyone with a possible exposure to HIV, either through sexual, injection-related, or occupational exposure. It is not PrEP, it's not pre-exposure prophylaxis, it's post, which means that it's used after an exposure to HIV. But the encouraging part about PEP is that in 2024, WHO updated the PEP guidance to allow community-based delivery and tax sharing for people who can provide PEP. So here's the paradox that we'll be talking about today. PEP, as we know, is one of the oldest and most proven tools in HIV prevention, but is also one of the most overlooked tools today in the prevention toolbox, and that's the paradox. According to the 2025 Global AIDS Updates, the role of PEP continues to be neglected and underutilized because of low awareness, fear of stigma, and health system barriers. And according to a global review published in the 2025 Journal of the International AIDS Society Special Supplement on PEP, we saw that 36 countries have PEP guidelines. However, only 6 of those country guidelines include community-based PEP access, regardless of the 2024 WHO recommendations to expand PEP to community delivery. So what we are seeing is that PEP is being written into policies, but it's locked inside clinics and hospitals. But the most alarming issue here is that there is no standardized global data on PEP use at all. The UN's monitoring system actually tracks whether a country has PEP policies in place, but not whether a single person actually receives or completes PEP. So we have a tool that works with evidence, it's poorly delivered, and it's barely measured. And we all know that when the data is silent, community voices become one of the few ways to actually understand what is happening on ground, which is exactly what the next slides will be highlighting. So as I mentioned earlier, the global data is silent, so I went directly to the source. I went to communities to ask what is happening. And I want to emphasize that this was not a scientific study. It was a short survey that was shared through community WhatsApp groups and networks ahead of this conference. But in a few weeks, I was able to reach 28 community respondents across 13 countries and 3 regions, Africa, the Americas, and Asia. These are not statistics, they are real voices of advocates and community leaders telling us what PEP looks like in their communities. And that is exactly the kind of insights we need to contribute to these discussions meaningfully. So here's what they told us. When we asked the community about the biggest barriers to PEP, two rose above everything else. The first was lack of awareness, and the second was stigma. And this was named by 23 out of the 28 respondents. And after these two came distance to facilities, judgmental providers, and stockouts. And layered on top of all this is the ticking clock. I think Dr. Andrew also highlighted that as well. PEP only works if you start within 72 hours, but 17 out of the 28 responded actually highlighted that communities don't clearly understand that there's a 72-hour timeline. And after-hour and decentralized services are also limited. So people are racing against a clock that they don't know exists, and they are racing to services that they may not reach on time. But here's the part that matters the most for this session. When we asked whether communities would use a shorter course of PEP, the answer was near unanimous. 23 out of the 28 respondents said yes, and 5 said maybe. None of them said no. Every respondent was open to it. And this is important because, as highlighted in Dr. Andrew's presentation, completion rates for PEP is still low. So maybe a longer acting course or a shorter course of PEP could help solve that issue. And when we asked the community what would actually help them, the wish list actually wrote itself. They mentioned demand creation to increase awareness, community-based service delivery to increase access, pharmacy access, mobile outreach services, and longer acting PEP. In other words, communities are already asking for what we're discussing today, the kind of innovation that this session is highlighting. The demand is there, but the question remains whether we are able to deliver it. So we've heard from the community. Now let's shift to country perspectives and national perspectives. What does it actually take for national policies and programs to move the product from evidence to implementation? And please be aware that this is not an exhaustive list. It just highlights the priorities. The starting point is almost always WHO guidance. It is extremely important because it serves as the foundation for national policies. We've seen this across the introduction of the new PrEP products. In many countries, including in Nigeria, the Ministry of Health takes the WHO guidelines and adapts them to reflect our national realities. The service delivery guidance from WHO is also useful. Training materials, monitoring tools are also adapted to fit local contexts. So WHO normative guidance is a critical first step. But whether you also need a regulatory approval for a new product actually depends on the product itself. And an example is the current PEP product we have right now, TLD. The recommended regimen was already approved and indicated for HIV treatment, so countries did not need an additional regulatory approval. They just took the WHO normative guidance, and with national adaptation, they were able to roll it out for use in country. However, for a new molecule, something that is not already approved for HIV treatment or for prevention, a national regulatory approval will become necessary before we can implement at scale. But there's an important shift happening right now at country level. We're seeing that across countries, including in Nigeria, the governments are increasingly focused on implementation evidence and not just clinical trial evidence. Phase 3 data shows safety and efficacy, but the Ministry of Health, they keep asking the next question. They keep asking, is it feasible? Is it acceptable? What does pharmacovigilance show? And how does this work in real life? And we're seeing this clearly with the new PrEP products like Cabele and Lenacapavir. And even with phase 3 evidence for safety among pregnant and breastfeeding women, we still see that some ministries of health are still waiting to generate real-life evidence before scale-up among particular populations. They are also asking for pharmacovigilance, they are asking for implementation data as well. So national priorities are increasingly around 4 things. Integration, which was highlighted by Max. Thank you for highlighting integration. Health system strengthening, sustainability, and operational feasibility. In Nigeria, for example, we recently combined our PrEP and PEP tools to really reflect long-term sustainability of HIV prevention programming and service integration. We must recognize that countries are no longer only asking, does the product work? They are also asking, can we implement this product sustainably, safely, equitably, and at scale, but within the existing systems that we already have? And this distinction is really important because it's what determines whether an innovation actually reaches the people who need them the most. So how do we actually plan for the future of PEP? By bridging these 2 sides. Communities bring lived experiences like we saw in the slides. They bring trust, they reach their peers through peer networks, and they bring the hard knowledge of real barriers like the 72-hour window or stigma or access. But country systems also bring policy, regulatory approval, pharmacovigilance, funding, and skill. And neither side can deliver the promise of long-acting PEP alone. We need to work together. And what connects these 2 sides is engagement across the continuum. We need to ensure early, consistent engagement that is not tokenistic. And that's the clearest lesson from Lenacapavir rollout. When communities are at the table, when communities start with the product, we see that trust can be built at the start, that the demand and the delivery systems are built even before the product arrives in country, and then there's demand for that product. So as we plan for the future of PrEP, for the future of PEP, we need to ensure that we build the bridge between country systems and community platforms from day one, because long-acting PEP is only as good as our ability to deliver it together. So I'll leave you with this message to leaders from the survey. And it says, in Uganda, especially among key populations such as men who have sex with men and people who use drugs, PEP access is limited by low awareness, stigma, and criminalization. Many fear discrimination when seeking services, and delays due to limited after-hours care mean missed opportunities within the 72-hour window. To reduce new infections, global leaders must prioritize stigma-free, decentralized, and community-led PEP delivery, integrated within broader HIV prevention services. I would like to thank all the 28 community respondents who shared their insights that made the heart of this presentation. And a big thank you to the Forum for Collaborative Research and WITRHI for organizing this session, and to the Root to Rise team who helped prepare this presentation today. Thank you.
Thank you for that wonderful talk, Adobe. My name is Ken Mayer. I'm Medical Research Director at Fenway Health in Boston and a professor at Harvard Medical School in the School of Public Health, and a longtime member of the steering committee of the Forum for Collaborative HIV Research. So now we're going to be moving into the discussion part of our session today, where we have additional panelists that I'd like to introduce, and then we're going to pose some questions to them. We would also like to leave some time for you in the audience to come to the microphone and ask questions. So our additional panelists at my far right, Adriano Queiroz da Silva is the Prevention Sector Coordinator for the STI/AIDS Coordination of the City of Sao Paulo, and a member of the Municipal Secretariat's Technical Committee on the Comprehensive Health for the LGBTQIA+ population. Next to Adriano is Kenneth Ngure, who's Associate Professor of Global Health at the Jomo Kenyatta University of Agriculture and Technology. He's also and is affiliate associate professor at the University of Washington. His current interests include ARV-based prevention, HIV self-testing, and interventions to reduce the risk of HIV transmission during periconception and pregnancy. He is a member of the Governing Council of the International AIDS Society and the incoming president of the organization. And online with us is Boitumele Semete, known as Tumi, Semete Makoko Slela, who's the CEO of SAFRA. And SAFRA is the South African Health Project Advisory Authority. With a background in biotechnology research and development, she has led SAFRA's efforts to strengthen South Africa's regulatory systems, including the approvals of HIV prevention medications such as lenacapavir.
Thank you, Ken, for introducing our panelists. And to me, it's so wonderful to have you here. It was also very nice to see you at the summit. I know, as CEO of SAPRA, you are extremely busy and you spent the whole day with us and listened to the conversations and provided input as well. So what were some of your key takeaways from the summit in Johannesburg?
Thank you very much, and good day, everyone. Apologies that I could not be there in person, but it seems like a really excellent session that is taking place. I think two key takeaways from us from a regulatory perspective and matters that we've come back after the summit and engaged on is around the need for data for PEP that will allow a regulatory decision. As many of you know, the currently existing regimens are approved as ARVs and therefore then utilized for PEP purposes. And so there is an internal conversation that is taking place around that. The second takeaway was around strengthening regulatory harmonization such that when a regulatory authority on the continent makes a decision, that how could that be accepted by other regulatory authorities to ensure that these therapies are accessible in the most efficient of timeframes. And with that efficiency, a key element, and our previous speaker made reference to that, is being able to collect data for pharmacovigilance, so wherein there would be any ADRs reported for PEP utilization. And because of the challenges around compliance, we are finding that we're not getting adequate reports to inform a pharmacovigilance strategy. Thank you.
Great. And then maybe a follow-up to that. What type of data would you want to see to even consider the review of an application for a PEP indication for a new ARV? As you know, we all know that currently PEP has no regulatory indication. It's based on guidelines and basically off-label treatment. But what would you like to see in terms of your agency and your collaboration across Africa and with the African Medicines Agency? With some of these trials that we discussed, do you think that would get your attention to review?
Thank you again. A very important question. And at the core of a regulatory decision is around benefit risk. And so when we look at the efficacy of a product, we look at the clinical benefit to any risks of harm. And so in this case, a critical component that we would require is clinical efficacy. And I think one of the colleagues spoke about implementation studies, or maybe we can call them phase 4 studies for PEP utilization, that a discussion around that would be helpful. One of the things that we started to do as regulatory authorities, and particularly in our case as SAPRA, is to have open and very early discussions with the PI around study design. So if there is a PI who is looking to do, whether it's a phase 4 study or studies to provide the clinical data, we're happy to meet with them prior to submission so that we can look at the study design and, whether that is the study is adequately powered, etc., and advise them before they can then make a formal submission to the regulatory authority.
Great, thank you so much. We have a packed room here, and I know everyone here is really appreciating your comment and your input, and we look forward to continuing our work together. I'll now pass it on to Ken to ask the other panelists some questions.
Yeah, I have some questions for Kenneth and Adriano. So what would you say is unique about your models of PrEP implementation? You each have some very interesting data to share. And then how would you use your model to help get the kind of information that would help inform decisions that regulators like Tumi would be thinking about? So I'm just curious, what's the model currently in the real world, and then how might it be used for data generation for regulatory approvals?
Good morning. Great to see all of you. I think this is a great topic. I always believe that PrEP has a lot of potential that needs to be optimized. Our model is the pharmacy model. Why the pharmacy model? And this is a private pharmacy model because we have seen that pharmacies are well positioned to deliver time-sensitive products because they're ubiquitous. Like in my own country, we have about 7,500 registered pharmacies. And when I travel to many of the countries, I'm able to see that pharmacies are very easy to reach. And we have also been able to do research to see that many people, about almost 50% of people, visit pharmacies regularly for their care. And they're even willing to pay for services that are free in public facilities because of the convenience. Secondly, pharmacies have experience in delivering some of these products that are time sensitive, including some post-exposure products. For example, emergency contraception. They have been doing that, and they have been doing that for ages. Thirdly, pharmacies are also motivated to deliver stigma-free services. And we're also seeing in the fourthly that in some countries, they're starting to include it in guidelines to consider pharmacies as potential places to deliver HIV services, both PrEP and ART. In Kenya, we started by having a stakeholder workshop when we started seeing these opportunities to deliver services, and we wanted to deliver PrEP. We called the regulators, we called provider associations like the doctors associations, the nurses, the lab associations, and we sat together and developed a pathway to deliver PrEP in pharmacies. And that was a small pilot. But what we learned from that small pilot on PrEP is that the demand for PrEP was much higher than even PrEP. And that's how we went on to this, a few other iterations. We went on and did an extension where we added PrEP, and were able to see that high need for delivering PrEP in that space. And then we have recently completed a 75 pharmacy cluster randomized trial where we are providing both PrEP and PrEP. And without stealing the thunder from that presentation that our team will be presenting on Wednesday, I just want to say when we provided both PrEP and PEP, about 65% of people actually came in for PEP. And then we're trying to say that this is an opportunity also to transition repeat PEP users to PrEP. And that's, again, we'll not get probably in more details on that, but just saying that this is a space that can be optimized and it's convenient, and there's huge demand for these services from that. When you think about the data that can be generated, is that when we are working with pharmacies, we are delivering government products. So we are using what we call a hub and spoke model, where each of the facilities, we have what we call about 5 hospitals, we get the products there and we give returns there. So whether we get either the products could be the PEP drugs, also the HIV testing kits, both self-test kits and rapid test kits, and then that is data we give. And we are also, because pharmacies are well positioned, even to get data on continuation and repeat users. And that is data that can help regulators to see how that space is working. Thank you.
Thank you. Adriano.
Hi, everyone. Good morning. Thank you for this invitation again, Veronica, Ken, Snage. We have been offering PEP for many years here, but you know that many people don't know about PEP. We observe that some groups some groups are well informed about PEP and PrEP, like gay community living in the center of the cities, but we know many people still don't know about PEP. So I think that when we refocusing our efforts to 2021, we change our efforts because we are offering now PEP on the street, for example. So we for our head leader she's in the audience. Every time that she say, I take a shower and I have an idea. One of this idea is the dispensing machine and e-health as PrEP, as PrEP online, as PrEP online PEP and PrEP. So I think our different service delivered in São Paulo that changed the prevention now is the e-health as PrEP and dispenser machine, because we know that we have more than 100 healthcare services offering PEP, but we know that many people cannot go to the services. So we are trying to put the HIV prevention where the people are. So I think São Paulo is improving this number, try to be together with the populations, and we observe that, especially for women, as PrEP and the dispensing machine is increasing the number of the users. Because we know that many women has difficulty to access, to speak about this kind of exposure, and when the people who has many prejudice or bad experience in the healthcare services can make a teleconsultation in PrEP and take the medications in subway stations or go to directly in pharmacies without other consultants. So I think the more important is we have to be where the people are.
Very good. Thank you. Thank you all. We can now open it up to a general discussion. I'm watching what's coming in online, but we also invite people from the audience to step up to the mic and ask your questions. While the first one, let's have, please identify yourself before you ask the question.
Sure. Cipriano Martinez from Australia. I just wanted to hear people's comments about, PEP, 2 weeks, a month for it to be effective. But from a community perspective, sometimes you just need 2 days worth, 3 days worth, maybe even 1 day's worth, just so that you can think about it. It's Saturday, I take it Sunday, so I've got time to access on Monday, Tuesday. And so sometimes I don't need 2 weeks or a month's worth of PEP. I actually only need maybe 2 or 3 pills, which is easy to carry, quite discreet. And that gives me the time to then think about and actually access the pharmacy and the other services, or if I have work, to actually coordinate my life to get access to PEP. And I'm just wondering, is that a consideration in terms of access that has been considered as part of these models? And it also resolves some of these issues that we have with the regulatory component of it, because I think from an Australian perspective, sometimes they historically have been concerned about the worried well. The worried well that access a month's worth of pill and suddenly these cost a lot of money and we don't want to be doing this, to everyone that gets concerned. But if they only have 1 or 2 pills or 3 pills and then they have a discussion with someone, then you can eliminate those worried wells while still keeping them safe. Anyway, comments?
Happy to make a comment. I'd be interested what the other panelists think. That's an approach I think that you're talking about is called PEP in Pocket. And Actually, one of the people who's done studies on this is in the audience. You may want to comment on this. Actually, I think I saw Daryl Tan as well, so maybe two of the authors, if Daryl is still here in the back. But Julie, I don't know if you want to comment about PEP in Pocket and what the experience has been in the UK, the idea of giving people starter medication. And then I'd be interested in what the other panelists think.
Yeah, we did a study 5 years ago called Home PEP, where people were given 5-day packs of PEP pills to start, and that covers you for the weekend and for the bank holiday. And then it gives you a chance to go to services. And what we found that people started their own PEP sensibly after the right exposures. And it was all set to be rolled out. And then our packaging within the UK changed, that we couldn't do 5-day packs and we could only do 28-day packs. So I think it's a good learning that we have to work with product developers, policymakers when you're doing your research to make it then have high impact. And Daryl did a different...
Thanks, Julie. Thanks, Ken. Yeah, I'll just share briefly that in Canada we've been...
Could you just also identify yourself?
Of course, sorry, thank you. I'm Daryl Tan. I'm an infectious diseases physician and clinical researcher in Toronto, in Canada. And yeah, thanks to the question and the redirection, Ken. We've been doing lots of studies on the use of PEP in pocket, as we call it, kind of PEP on demand. In our setting, it often comes up in the context of a PrEP clinic or an initial PrEP consultation in which, after a careful assessment and consideration of different options, one realizes that, the person actually is kind of in that worried well category that you referred to, and this way they leave the clinic with a prescription in their pocket, a biomedical intervention that they feel more confident using, and then they actually seldom really use it. We've emphasized in our Canadian guidelines, which were recently published on World AIDS Day in December, that this is an option we'd like to make more widely available. We do emphasize that the evidence base behind it is actually, of course, not nearly as robust as for PrEP, and so for many people, PrEP on demand might be more suitable, but we think it's an important tool to have in the toolbox. Yeah, thanks.
Hi, it's Gus Cairns from AIDSMAP and the ATG. I was in the excellent prevention satellite pre-conference meeting yesterday, and I'd like us to stop talking about what people want in terms of prevention, because what men and women particularly want and need may be very different from each other. PrEP depends on anticipating that a risk and that you intend to take it. Women are much less likely, and I'm not just saying this as a woke thing, the data says that women are much less likely to be able to anticipate when and the kind of sex they have. And so PEP is potentially a measure that women in particular might benefit from, might use. And I think there was some data presented, I can't remember who did it, at the prevention meeting, which showed that women disproportionately actually access PEP compared with how many of them access PrEP. And we spend a lot of time scratching our heads thinking, how do we get PrEP through to women and how do we get them to continue using it? PEP may be the thing that they actually need, or that a high proportion of them may need, and some of them may then decide to take PrEP, as somebody has already said.
Thank you. Thank you for that comment.
Thank you. I'm Holly Janes. I'm a biostatistician in Seattle at the Fred Hutch in U.S. And wanted to thank the comprehensive presentations, and especially Andrew's presentation around the potential clinical trial designs. And I wanted to ask about your first design, the counterfactual placebo approach. And you made reference to the Purpose 1 and Purpose 2 trial designs, but as I understood your conception of the counterfactual placebo, it seemed that there was no internal control. It was purely leveraging the counterfactual placebo, which is, of course, different from the Purpose 1 and Purpose 2 trials that did have the internal active control, as well as the counterfactual placebo, perhaps a safer, less risk-prone approach, in the event that the counterfactual placebo doesn't represent the population of interest, or the approach to estimating incidence in that counterfactual placebo didn't work. So I wondered if you could just elaborate on that potential approach, and if that's part of your considerations. It seemed that you were inclined towards some of the other design approaches, but how are you thinking about that, in particular in the regulatory perspective?
Thank you for the question, and thank you for your contributions to the field. So maybe I went too fast over it. What I was saying is that for the counterfactual placebo, it have an active comparator actually, which is the standard of care, PEP, the 28-day PEP, against the single-dose novel acting agent with a counterfactual placebo. Did I understand your question correctly?
I see, but it's not a randomized active control, as I understand it?
Oh, so it would be like PURPOSE 1, where it would be randomized. Yes, it would be randomized. Yeah.
Okay. I guess, yeah. So I guess I need to think more, understand that one more deeply. Thank you for clarifying that. Thank you.
You're welcome.
Hello, Hugo from Guatemala. In my country, 3 drug regimens are actually mainly available to people living with HIV through HIV clinics that provide treatment, but not really prevention services. And most PEP prevention services are provided through NGOs specialized in at-risk populations only as 2 drug regimens. So, from my perspective, scaling up, well, I know the WHO prefers a 3 drug regimen and says that probably a 2 drug regimen will be effective. I don't know if you have any insight to this, because I don't think that some countries have a really availability to provide PEP as a 3 drug regimen.
Do some of the panelists want to respond to that 2 versus 3 drug controversy? Do you want to? I'm sorry. His point was that in some countries, because of resource constraints, 3 drug PEP is a luxury, and what about a 2 drug post-exposure regimen?
That's a good question. I think even for treatment, we are now seeing that 2 drugs work as well as 3. And so for cost consideration, I think 2 drugs, if they're effective, can be used as PEP. But we just don't have the evidence to inform that. We will have to infer that from what we're seeing in treatment. And we hope that, hopefully, and I know this may be controversial, but we may be able to go to single drug PEP. 1 and done. Take it and you're done, because it's long acting. But we need the evidence to inform that.
Yeah, there's a couple complications. One is we have very little human data from clinical trials that would inform making a decision. So most of what we say about PEP is based on animal models, and the animal models are limited in the sense that they're expensive, and therefore they're not doing huge numbers in every permutation. But there's the one variable that we didn't discuss very much yet today is the time that you take the medication in relation to the exposure. And clearly, as Andrew showed on one of his slides, the founder effect, the longer time you leave for HIV to replicate, you're playing catch up. There's already a substantial reservoir that you're trying to contain and allow the immune system kick in before it becomes a disseminated infection. So the animal data would suggest that probably you could get by with 2 drugs if you give them early. But how early is early, and how much you can extrapolate from macaques to humans is the controversy. But certainly, the longer you delay, you want to have the luxury of the 3rd drug. But again, as you heard from Max, there's a lot of consideration why alimatravir, MK-8527, might be a really excellent choice, a one and done PEP regimen. And I think, what we're trying to struggle with is how do we do clinical trials so we have enough information that can give comfort to regulators and to the community that this is a safe option. But hopefully in the future we could get to 1 pill for PEP, which would certainly be a radical transformation.
Yeah, those are good points. And if anyone else from the panel wants to comment on that, I do have a question online. Should I go to that? For the PEP dispensing machine model, could you please clarify a bit more on whether or not there is a need to see any doctor or nurse to get a PEP prescription? If yes, is this available online?
Yeah. For pick up the medicines, and dispenser machines have to make a teleconsultation in S-PrEP, is a e-health service. So for PEP, you don't need to upload a HIV negative test, because the sooner the better. So to just request the teleconsultation and go to take the PEP. You can pick up the PEP in 24-hour services, or dispensing machines, or other services specialized also. So for the sooner the better. So it's fast. It's fast.
Any other questions from our audience members here on some of the clinical trial designs, the feasibility? Maybe Adobe, we'll ask you. How do you feel being here at the International AIDS Conference in Rio de Janeiro, and what are you looking forward to here in terms of news on PEP and collaboration building, etc.?
Thanks for the question, Veronica. I feel grateful to be here. I had issues with my visa getting here, so I'm very happy to be here. But also very grateful to be representing the voices of the community. I think my major aim at this conference is to elevate community voices. As we go into technical discussions, science-heavy discussions, we also need to elevate community insights in a way that can resonate with the scientists, with the regulators, with the donors, and with the implementers as well. So my major aim here is to elevate community voices and ensure that as we work towards the future of PEP, we're doing it in a way that reflects the preferences, the needs, and the lived experiences of the community. Thank you.
Hi there. Hi, everyone. I'm Sindra from AVAC. This is a question from Max. On your slide, you had 4 weekly PEP, 4 times a week, 4 times a month. And I was wondering, is that specifically, do you have weekly LEN in mind for that?
In the options that we are looking at, in terms of the three-legged approach of PEP, PrEP, and treatment. So those are potential options that will be available in the near future. So if you had a weekly pill, that could be a combination of LEN plus islatravir, right? That should be coming soon. That could be an option for somebody to take 1 pill once a week for a whole month, right? So where it might not be completely optimal is the fact that you have to take a loading dose for LEN. And so that might not be the perfect 1 pill once a week. However, there are other 1 pill once a week that are being worked on that would not require loading, for example. So if you think about how many people actually finish a course of PEP for 28 days, it's only 33% of people take it the whole month. So already you're dealing with people not being compliant for 28 days. So that's why we are looking for long-acting options that are going to be better, I think, at addressing PEP. So the other options I had is 1 pill 1 time. If you can maintain that PK for 28 days, then that will be even much better. And that's the leap we've been talking about, right? To go from 3 drugs, bypass 2 and go straight to 1. And that's why Veronica is saying, and I agree, we need to study it very properly, right? To make sure that that 1 pill can work by itself. Already we are working we are funding a study in non-human primates to actually look at that 1 pill in non-human primates to see how it works. And the next phase is going to be to go into humans.
Hi, everyone. Sebastian from Ecuador. Thank you for your presentation. And my question would be, if you were advising a hybrid clinic that combines the community-based model with the clinical attentions, what would you advise from the two from now the next 2 years for becoming a research site that can expose the evidence, and how can we use this information in Latin American context, you know? And I need to say this, there's still doctors that don't know what's PEP in our context. So it's really difficult understanding that as a healthcare professional. And research in Latin America, at least in Ecuador, is really poor, you know? So as this platform, as a community center care creates, what do you recommend for us to, or how do you advise, what do you advise to us, and how we can share this context?
I wonder, Adriano, would you feel comfortable responding? I think none of us want to be too prescriptive, but you've created a model, a public health model, of being able to do research and practice of what lessons might be generalizable for other Latin American settings.
Many people don't know PEP, even healthcare servers, healthcare professionals. You are right. So I think we have, for example, we have data, we have good products, we have a future of the good products like Max presented for us. But so we have many tools in the box to face the HIV epidemic. But in many cases, the boxes are closed. The box is closed. So we have to open the box. Because if you don't inform the people, inform the community don't ask to the government, to the society about the HIV prevention. So I think we need to engage with the movement and go together with them, because I think in Brazil we are privileged because we have a public system very strong. But even in Brazil we have many places with the box closed. So we have to open the box and offer the HIV prevention. I think PEP is not a good way now. It's a good way to HIV prevention, but we don't have to. We need to make the PEP the real gateway to prevention, like we do with PrEP. Many people take PEP in urgent and emergency care services, and they take PEP and let go. Bye-bye. Different of PrEP, you offer vaccines, condoms, lubricants, other kinds of strategies. So I think we have to chant in the same way of PrEP, like PEP like a PrEP, because PEP must be a real gateway to prevention, expanded prevention.
Thank you.
I wanted to add something about provider training, because I think it's facing many of our countries. The traditional model of provider training, where you would get people for a few days and train them, is actually now becoming old-fashioned. We need to come up with new training modalities that can be able to reach more people, especially as we get newer tools. We can use the mobile tools, we can use IT technology, we can use many other models of training that can be able to reach providers, so that then we ensure that they get the information. We just need to be context specific, look at our local context and see what is more applicable as opposed to the older training modalities.
I think our last question.
Thanks. I'll be quick, and it's not a question, it's just, I just wanted to kind of add to this conversation around kind of these challenges that we've been talking about around kind of PEP uptake, and I think this sort of PEP being really kind of put in this sort of emergency bucket as opposed to being part of the kind of ARV-based continuum. And I'm Stacy Hanna from AVAC, sorry. And I just wanted to let everyone know we're going to be looking at this issue around kind of how do we kind of create a PEP advocacy campaign. I think it's tomorrow in our zone at 4 o'clock. So if anyone is interested in kind of having more discussion about this and really kind of workshopping what should we do to really raise the awareness amongst communities, providers, policymakers, please join us. Thanks. Oh, Global Village. Yeah. Thanks.
Thank you. I guess the very last one?
Yeah.
Sorry, and thank you for letting me ask. I'm Diana I'm Bolivian, but representing Brazil. So I work in a project that is implementing PrEP among adolescents, 15 to 19 years. But we see that almost 15% of them needed PEP. Half of them at the beginning, at the first visit, but also half of them, the other half needed during the follow-up. Even using PrEP, they were with low adherence, and then they needed to use PEP during this process. And 2 of them needed to use at the beginning and also during the follow-up. So I wanted to ask some 2 brief questions. That what happens when there is another exposure while using PEP, like they are in the 28 days of using PEP, and the adolescents have, for example, another risk exposure? It should start again the count for the 28 days. And if there is any recommendation for people who arrives at the service after the 72 hours of the exposure, is there anything besides just waiting for the testing results, and what it happens, like, for example, 4 days after the exposure, if any new meds that are being planned are also going to take care of this part? Thank you.
Thank you. Anybody care to respond? So the questions are re-exposure during the period of the initial period of PEP, and what do you do after 72 hours? Andrew, looks like you have the mic.
Those are great questions and practical questions from the field. So it is true that some people have repeat PrEP exposures, and the guidance is then to transition them to PrEP. We know that transition rates are not as good if you leave it up to the people. Not many people transition. But Julie's here. In the UK, they've been intentional about transitioning people from PEP to PrEP and supporting them in that transition. Others can't just keep taking PEP repeatedly. The other question was about what do you do? So I heard 2 days ago about this. What do you do in that window? It's after 72 hours they've had an exposure. And thankfully we use the same drugs, TLD is available for treatment. And what some people are doing is just keeping the person on a 3-drug regimen and waiting for the results to come back. If they are positive, you continue them on the same drug, because that's the same drug for treatment. And if they're negative, then you can just use it as PEP. It's the same 3 drugs you can use for both. And the beauty of his strategy that Mark shared is that we use the same tools for all 3. And that's really where we should be going to.
So thank you. Thank you for all the questions. And we now need to close because we're getting up to the time. I want to especially thank Tumi again for joining us. I hope we will see you soon again in person as we continue these conversations among the African Regulatory Network. Thank you so much, Sinead, for being here and for the collaboration with WITS RHI. Thank you, Ken, for your constant support and participation in our work. And, all of our presenters and panelists here, Max, for supporting our project. And thank you to all of the audience and your questions for being here. Thank you, Logan, and for keeping us on track. And with that, I think we say bon dia. Obrigado. Obrigado.